I am Jagrat.
And I'm Shambhavi. We're from Querentia. We're a group of medical students from Lady Hardinge Medical College, and we're working towards achieving health equity and gender and sexuality inclusive healthcare.
For the participants and speakers who've been with us from the very beginning of the series, Demystifying Gender, Fostering Gender-Friendly Healthcare, we hope it has been a great learning experience for you, as it has been for all of us, collaborating with Athi in association with WPATH, under the guidance of Dr. Harish Pemde, and with the assistance of WHO Collaborating Center for Adolescent Health. Today, we welcome you to our fourth and final webinar, Building Nurturing Environments. In the words of Glenn Close, what mental health needs is more sunlight, more candor, and more unashamed conversation. And today, on World Mental Health Day, we are here to shed that extra light on mental health and have lots of unashamed conversations.
We'd like to take a few moments to reiterate the ground rules for the webinar. We'd request everyone to share their pronouns and use gender-neutral language and avoid binary terms as much as possible. Please avoid using terms such as patient and consider words like individual instead. Please note that homophobic, racist, or sexist comments in this space will not be allowed. Please have a growth mindset and be open to making mistakes and recognize the difference between intent and impact. Please be respectful throughout the interaction and be mindful of all human forms and human expressions. We'd also like to take this moment to say that this webinar covers sensitive issues related to mental health, specifically of people with gender incongruence and differences in sexual development and orientation. Some members of our audience may find certain aspects of the webinar distressing, so we would like to take this moment to ensure that you feel free to step away from the conversation momentarily. Without further ado, I would like to invite Dr. Harish Pemde, the Director Professor of Pediatrics and the head of the WHO Collaborating Center for Training and Research in Adolescent Health at Kalavati Saran Children's Hospital, LHMC. We welcome you, sir.
Thank you, Shambhavi, and thank you, Querentia, for thinking about this issue and for managing such a good program, a series of webinars on this, a very, very new issue for us, all the doctors who provide care. First of all, I would like to welcome our new director of Lady Hardinge Medical College, Dr. Ramchandar sir, who's a director professor of dermatology. But beyond this, I would like to introduce him as a person who has been deeply involved with adolescent health. I remember him participating in 2009 and 10 about adolescent job aids, which program which we had in Lady Hardinge Medical College. And since then, he has been associated with various activities related to adolescent health and as a dermatologist. And he has been in charge of this STI clinic. The STI means sexually transmitted infections clinic and all the related activities thereon. And being a dermatologist, he is very well aware of the body image issues, which definitely emerge in young people with even one acne or several skin-related issues. So we are very fortunate to have him in our college and also in this webinar, which is based on gender-related issues. And under his guidance, we shall definitely be able to have gender affirmative care in all the hospitals of Lady Hardinge Medical College, not only in the hospital, but in the teaching of the students, whether it is undergraduate students or postgraduate medical students and nursing students also. So welcome, sir. And I would request you to say a few words on this occasion. Dr. Ramchandar, sir.
Yes, thank you, Dr. Pemde, for nice words and kindness that you have shown in inviting me for this program. I see this is a wonderful initiative by this Querentia team on the adolescent health and affirmative gender equality healthcare, and that also targeting those who are not targetable sometimes, and they have difficulty in approaching the healthcare systems. sometimes healthcare is not available to them in each and every corner of the country. This is significant and sizable population in our country, in every country too, where some of them, they are identifiable and some of them, they are not identifiable. Sometimes they are oriented differently. They look different, but they are different physiologically and anatomically. So targeting this sizable, equally important population among ourselves, I think this is a very good initiative the team has taken up. This is going to give a good message, and the team is going to be a torchbearer in taking this message forward, that when we are as healthcare individuals, healthcare providers are coming across or facing this population, we should be gender neutral and we should be empathetic toward them, and we should understand their need, particularly on World Mental Health Day, having their mental challenges or these challenges, particularly in the mental health, is going to take another steps in the right directions or the positive directions. And this is going to have a positive vibes and initiate them and take away their sufferings in coming and providing by us a holistic and comprehensive care toward them. With these words, I wish you all the best for this webinar and the last webinar in this series. I take this opportunity to extend my warm welcome and greetings to the teams of the adolescent under the leadership of Dr. Pemde and the other luminaries who are going to take participations in this particular webinar. Thank you.
Thank you very much, sir, for your blessings. And we shall be in touch with you for implementing various learnings from this series of webinar in J.D. Hardy Medical College. And thank you very much. Please continue joining us as much time as you have now. We shall be grateful for that.
Yeah.
Thank you. Now I invite Mr. Alok Saxena, who is an additional secretary in the Ministry of Health and Family Welfare, who is also the Director General of Central Government Health Services and National AIDS Control Organization. He also looks after Pradhan Mantri Jan Arogya Yojana, and he is an officer of 1989 batch of Indian Postal Services. He has been on the various posts in Ministry of Home Affairs, Personnel and Training, Tourism, Pay Commission, and Ministry of Finance. With his vast experience and current charges of the NACO and Pradhan Mantri Jan Arogya Yojana, we definitely expect lots of issues to be taken up related to gender affirmative care under his leadership, under his guidance, as these things are very much required. Can someone share his slides, please? Shambhavi?
Just a second, sir, sharing.
Okay. It is okay if the slide is not there. Yeah. So I again welcome from J.D. Hardy Medical College, Team Curentia, and on behalf of Pati Mr. Alok Saxena on this platform. And now I will request him to say a few words of blessing and give a keynote address on the issue.
Dr. Harish, Mr. Alok is probably delayed. So can we request Dr. Bela Sharma to give his talk, and then we'll come back to Mr. Alok.
Okay.
Dr. Bela is there. Dr. Bela.
So Dr. Bela Kamaraj is the country director of India for Joint United Nations Program on HIV/AIDS, UN/AIDS. And he has served as the country director for Nigeria. And he's a medical epidemiologist with master's degree in public health and a university degree in health in developing countries and certificates in HIV/AIDS, STI, clinical sciences and epidemiology, tropical epidemiology and medical virology laboratories from respected universities across the globe. Epidemiology is a very, very important science which all clinicians should also know, because this only determines the various details of any medical condition, and epidemiological description of the gender issue will be very, very important to learn. And I'm sure with his vast experience, he will enlighten us on this issue. Dr. Bela Sharma, please say a few words. Dr. Bilali, please unmute yourself first.
Great.
Yeah.
You hear me now. Excellent. Thank you.
Yes, yes, yes.
Thank you. Thank you very much. Respected Sri Alok Saxena, Director of General of NACO, respected Dr. Harish Epemda, Director WHO Collaboration Center on Training in Adolescent Health, respected Dr. Kavita Aurora, alumni LHMC, Dr. Sanjay Sharma, CEO ATI, respected speakers and participants, let me congratulate you on behalf of UNAIDS for many achievements made in India, from the recognition of transgender as a fifth gender in 2014 to ending the Section 377, passing the TG Act and HIV Act, the establishment of a national TG Transgender Council at the Ministry of Social Justice and Empowerment, the annual reporting, the voluntary reporting to the United Nations General Assembly on the well-being of the LGBT population, and many more achievements in social protection schemes for the most vulnerable and marginalized in societies, including our LGBT communities. Each of these are part of a holistic public health approach to address the needs of the LGBTQ plus community in India. We talk about community, we will not talk about individuals, because the communities are the ones who are living and thriving together to really make sure that their issues are understood. Today, we are gathered thanks to the ATI and LHMC for the fourth webinar and last webinar for transgender health. And I hope this will not be last, but it will be a last in a series. This is again another step to build a social revolution, a lightning in the darkness for a better and inclusive India. And certainly the rest of the world will learn from this process as usual, because what happens in India reaches the rest of the world. Looking at a comprehensive article published in the Journal of Psychosexual Health in 2020 by Dr. Jugrati and Advaita, entitled, "What Do We Know About LGBTQ plus Mental Health in India?" A review of research from 2009 to 2019, 10 years. The authors found many important issues, from depression, suicide, substance abuse, low self-esteem, deprivation, including economic status, rejection, social stigma, and other health and mental health issues. The proposed areas of research in health and mental health for LGBTQ in the next decade. And using these areas, India can develop major public health structure to address these needs and all related issues such as social protection, human rights, and social justice for the reduction of inequalities. Ladies and gentlemen, dear participants, let us be clear that health, including mental health of transgender, is determined by their life experiences, the social and family rejections, workplace discrimination, and non-acceptance by the society at large. All those put them at risk of not getting educated and skills necessary to live a decent economic life and having access to quality health care. Therefore, I'm inviting ATI and the LHMC to develop holistic approaches considering these specific needs of LGBTQ plus at different stages in their lives, from childhood to adolescence to adulthood and old ages, as they will need different medical, mental, and social support, psychosocial support, and these needs must be met. In September 2018, the government of India launched Ayushman Bharat, the universal health coverage, with the aim to provide comprehensive health insurance benefit to the poor, the socially disadvantaged, and rural populations. As a follow-up, with the support of WHO and UNAIDS, in September 2019, a national consultation on universal health coverage was held in Kolkata by civil society, including the transgender community. Its aims was to discuss progress on Ayushman Bharat and as essential parts of the Sustainable Development Goals to be reached by 2030, so that all citizens of this beautiful country have access to quality and affordable health and wellness services. Today, we can say clearly that this opportunity, the government of India has incorporated this component into Ayushman Bharat, including gender-affirming surgery for transgender people. My congratulations to you all. As together, we are moving toward in building an inclusive humanity. Therefore, we have the opportunity to build a comprehensive public health system which will meet the needs of the transgender at every step of their lives, from childhood to adolescent ages to adulthood and older ages, so that a young transgender in Rajasthan will be cared for. An adolescent transgender in Telangana will have access to all necessary health and psychological support. An adult transgender will have all the access to health care he or she needed in Tamil Nadu. And also an old transgender in Bihar will be taken care of to address her or his health issues imposed by age, including the chronic and non-communicable diseases. Dear leaders, friends, and colleagues, let us forever remember that the family and the society at large should be educated about the health issues of transgender to understand their needs for a holistic care which will help them to enjoy the whole potential of their lives at family, community, school, and workplaces level. Let us forever be driven by the Madras High Court statement. Human rights are non-negotiable, and ignorance cannot justify discrimination. Indeed, access to health care, access to health in general, is a fundamental human right for all. I want to thank you for your kind attention and wish you a very productive webinar, keeping in mind that transgender health is a human right issue. Transgender health is a health issue, but transgender right is certainly giving the opportunity to the one who can be productive in their lives, in their communities, to really make sure those are met, those are happening. I want to thank you again for this opportunity on behalf of UNAIDS and all our 11 co-sponsors, and to tell you together we can make it happen. Thank you, and now best regards.
Thank you, Dr. Kamara, for your wonderful comments, and you showed a great understanding of the issues and knowledge of the developments happening in India. That was really, really great. I would just like to say that all the doctors and healthcare workers also need to understand that health is a right, fundamental right, I would say. And looking at the health issues as a right of the individual is very different than having a look at the issues from a medical point of view. But we need to consider it as a rights issue also, which is a little different than the other way of considering the health issues. And we need to learn on it. And transgender health is definitely is a health issue, a medical issue, and human rights issue. Certainly. Thank you very much for your excellent comments. Now I invite Dr. John. Dr. John is a very right person in today's webinar. He's a professor in mental health as well as in transgender health. So during this mental health week, we are celebrating. He's a very appropriate person for this webinar. He's a member of WPATH and European Path also. He co-chairs the Standard of Care 8 for WPATH, the global guidelines for transgender health services. He is an elected member of the International Academy of Sex Research, the Eating Disorders Research Society, and the European Society of Sexual Medicine. He also leads the Managed Innovation Network in Gender Diversity and Wellbeing at the Institute of Mental Health. Currently, he is a PhD supervisor at Nottingham University. Dr. Arcelus has over 100 publications, and he is an associate editor of International Journal of Transgenderism. So lots of things to learn from you, Dr. John. Please have your keynote address on this occasion. Dr. John, I welcome you.
Thank you very much for inviting me to be part of this. I'm going to try to share my screen with all of you. Yeah. And I'm pleased that you mentioned, you say my surname right, which is not usually an easy thing to do. So I am based at Nottingham University in the UK, and I am one of the co-chairs of the Standards of Care. So I'm going to just talk a little bit about the Standards of Care 8th edition, and mainly about the methodology that we are using. The Standards of Care 8th edition are hoping to be published at the end of this year. So I will not be able to say much about the content of it, but I will talk you through the methodology of that. I'm going to say a little bit of history just to put things into context. And if we go back into the 1800s, and there were not words for researchers and health professionals to describe those people whose gender identity was different to the sex assigned at birth. And transgender and gender diverse people, as we know them now, they were regarded as sinners or moral failures. And in the 1940s, 50s, in Europe and in USA, they will see transgender or transsexual, as they were known afterwards, as some kind of intersex people, sometimes between male and females, whilst at the same time, the law was criminalizing surgeons who removed what they believed to be healthy tissues. In the 60s, 70s, again, Europe and USA, they started to develop gender clinics and to try to study trans people and provide treatment. And that's when they started to develop protocols for treatment. And that was in 1979 when the Harry Benjamin International Gender Dysphoria Association was formed and was published the first Standards of Care, which was called the Standards of Care, the hormonal and surgical sex reassignment of gender dysphoric person. These Standards of Care were then published in 1980, 81, 90, 98, and 2000 and 2011. And the last one that we have is the Standards of Care 7, which was published in 2012. And that was based on consensus, with 34 people involved on that. And they are quite important. They are very important worldwide. If you look at the Standards of Care, if you put SOC in Google, you will have about 232,000 results. If you look at PubMed, you'll see over 5,000 articles. But not only that, but a lot of countries use the Standards of Care to develop their services. And in the USA and other countries, they use that to decide who has treatment and who has no treatment. So 4 years ago, WPATH decided to start a new process of developing the standards of care 8. But they wanted to do this in a different way. They wanted to do this not consensus-based, and they wanted to involve more people. So they were hoping to do more evidence and consensus-based as well. And this is what we're trying to do. We're trying to develop a guideline. And it's important that what a guideline is. Guideline is a recommendation. It's not policy. It's a recommendation that intends to assist providers and recipients of healthcare and other stakeholders to make the informed decision. And the standards of care 7 were translated into different languages. You can see the peak variation of languages here, which shows how important around the world they are. So as I said, the standards of care 8 was going to be different. It was going to be very much evidence-based, and it was going to involve more professional stakeholders. The evidence on transgender health has moved quite a lot over the last years, but obviously because of ethical reasons, there is not evidence for everything. There are some research projects that they cannot be done. So it was important to have a lot of people, a lot of clinicians and academics and clinical academics and stakeholders, because those are the ones who will be able to give their view as to what it was right to recommend and what it was not. We will use a Delphi system to reach the agreement, and we will be including new chapters. So we first review the SOC 7, we develop questions, we undertake a systematic review, we develop statements, we vote those statements of the 128 people who were in the SOC, and we grade them and write the supportive text. And I'm going to go briefly through this. But the first thing they have to do was to select the members. So they wrote job descriptions, applications, and they select the people. And here is an idea into what happened. So Eli Coleman, who is the chair, remained as the same chair as the standards of care 7 to just to have the same person through the 2 standards of care. And myself from the UK and Dr. Asa Radix from New York were appointed as co-chairs. Then we had 50 applications for chapter leads from 18 different countries, and 24 of them were chosen. And then we had 164 applications, again from 18 countries, to develop the teams for every chapter. This gives an idea as to where the chapter members came from. So as you could see, they come from all over the world, but because the literature is much more westernized, much more USA-based, much more European-based, we'll have bigger representation of people, but we hope that in the future there will be people from other countries as well. So the next section was to define the chapters. As I say, we'll review the SOC 7 and we see what new literature has been out there and which are new areas. So we have a global applicability, which was the same as the previous one, to see how we translate the SOC globally around the world. We have a terminology, epidemiology, and an overview. And then we decided to divide the children and adolescent chapter into 2. We thought that there were aspects of trans health, which was very different for children than for adolescents. So they become 2 different chapters. We have a new chapter, which is about assessment as to who will be benefiting from hormone treatment and surgery. We have a new chapter for non-binary individuals. We have a chapter in mental health, which we call it mental and behavioral health conditions. And we have a new chapter in primary care for adults. Although primary care was mentioned before in the SOC 7, this will be a whole chapter in primary care. And then we'll have a chapter on hormones, a new chapter in sexual health, and the chapters as last time in reproduction, voice, surgery, institution, and intersex. And we'll have a new chapter in eunuch, a chapter in education, and a chapter in ethics. So that gives you an overview as to what the chapters in the SOC 8 will look like. Just to give you an idea as to what the chapter leads are, again, there are still 2 USA based, if you ask me, but we have people now from the UK, from Belgium, from the Netherlands, and from Germany, but again, mainly Europeans and from USA. And the next stage was to select a good team who was very much, had a lot of experience in literature review. So we selected the Johns Hopkins University, and we worked together with the team, Karen Robinson, who is a picture of her there. And she guided us a little bit about how to develop statements, how to go through the process of Delphi, and how to understand the literature reviews feedback. The next stage was to conduct a systematic literature review, and once it was conducted, that will be shared with the rest of the team, and then we will develop the statements, the draft statements. And once the draft statements were developed, those are statements that have to say to people what we recommend and to whom, and they have to be as clear as possible. And it took quite a lot of years. As I said before, we started this process 4 years ago, and we haven't finished it yet. So it has taken quite a lot of time. Then we put the statements through voting, and 128 people everybody who was involved in the SOC was able to vote. We have to have 75% acceptance in order for the statements to be successful. And we have to go through 3 rounds of that. So if it was not approved at the beginning, we will just collect all the information and feedback. We'll just modify the statement and we'll go for a second round. And we'll do that during 3 rounds. Once the 3 rounds were completed, if there was not successful, then we will just remove the statement. Once the statements were approved, then we'll have to grade them, and we'll grade them based on the evidence, but not only on the evidence of the literature, but on the evidence and the experience of the clinicians and clinical academics that they were involved on the SOC. And as you can see here, there are different kind of gradings. Obviously, the RCTs will be the top ones, but you cannot do an RCT for every single part of trans health. We just have to be realistic on that. And sometimes the clinical experience is one of the most important things. So we'll be grading based on that. And based on that, if it will be a strong recommendation, we will say we recommend. And if it was a weak recommendation, we'll say we suggest. Once the statements and the grading happened, the teams will be writing the supportive text using the literature. And that will take quite a long time as well. And at every single stage, all the information will come to the chairs and we'll have to approve to move to the next stage. And lastly, we wanted to make sure that the references that the teams and the chapters have used were the right ones. So we'll have an independent group of people who will be checking the references to make sure that those references were supporting the text. We'll get feedback from them. And lastly, they will be send every single chapter to an editor. So it looks like the SOC 8 will be written as one person. So where are we now? So we all the chapters have developed the recommendation of the statements, and all the statements have been approved by the 128 members. As I say, some of them have to be deleted, and after modifications, some of them were approved. The chapters are writing the text supporting the statements. We have 9 chapters which are finished now, and we are with the editors, and 8 chapters that are about to finish. The rest of the chapters are at the last stages. And something that it took a long time to approve was terminology, because terminology is something that is changing all the time. But we have now a terminology chapter that has been accepted. And what do we do? What do we expect to be different? We expect the SOC to be closer to the ICD-11 than the DSM. We are very keen to depathologize, and obviously the ICD-11 doesn't talk about mental health when it talks about trans people. So we're moving away and we're questioning the role of the mental health worker as a part of the assessment, whether we need a psychiatrist or psychologist as a part of the assessment. That is likely to go away, and the role will be different to what it was in the past. We also will be reviewing the number of opinions in relation to surgery and much more. As I say, at this stage, I'm not able to say the content of the SOC, but the SOC will be out there quite quickly, and we hope to finish by this year, by the end of this year, December 2021 or January 2022. will be a 2 weeks period at some point in November to get feedback from everyone about the SOC, and we'll collect that feedback in December to make sure that we hear the voices of everyone. So at that point, I will just finish. Thank you very much, and I will stop sharing.
Thank you, Dr. John, for wonderfully explaining the process of making these standards. And many of our students, they are listening to this process for the first time. It's a very, very rigorous process of making any guideline or standards based on various kinds of evidences which are currently available. Just one question to you. How do you include the aspects related to cultural context in these things? And also, how do you include the policy environment in a particular country or in a community? Because these two things are very, very important for implementation of any policy or guideline.
Yeah, I understood your second question, and the global chapter will try to just look into how we can translate the SOC 7 in different countries. And as I say, some of them will be recommendations that they will be very much based into what is available out there internationally. And we are very realistic that if we recommend to do certain aspects, that in some countries they will not be able to do those aspects because they may not be able to have those professionals and so on. And that's why I think, those are the kind of the top ways of working in trans health, but people will have to adapt them as it fits best for their country. We just have to be realistic on that. But the most important thing is that the doors of trans people for treatments are not closed. But those are the very much the kind of the very best that the countries can do. And WPATH hope to put training in relation to the standards of care so people can be educated around that. But we are very aware that we could say in the UK, they will need to see all these kind of professionals, whilst in other countries, they may not have those kind of professionals. So those are guidelines. And that's why I put that in, that this is to guide the health providers. This is not policies or law. This is just to guide them.
Yeah,
and I didn't get your first question, sorry.
It was related to how do you include the cultural context related to the issues?
Yeah. So it goes into that. I mean, we hope that the global chapter will look into that, and we have kept that in mind all the time. I mean, we have people from all over the world involved on the guidelines, and as I say, the SOC 7 was much more USA based. The SOC 8, we hope that it will be much more global based, but we acknowledge that it still will be much more Western from the Western countries and from the USA, and we have to be realistic on that. And I think for every single statement that we look as chair and co-chairs, we think, how is this going to be implemented in somewhere where they don't have those resources, really. But again, this is a guidelines, and I think it was important that we provide guidelines that they are the best possible, instead of just having the kind of the least possible for trans health. So the best possible, and people will have to adapt to that and see what they can do in their own countries.
Another issue which people are raising, that what has been the participation from this transgender community or people from various other countries or continents like Asia, Africa, Latin America, so that their guidelines become internationally relevant.
Yeah, I mean, we have people from all over the world in the SOC. We have trans people, of course, and many of the people who are involved in the SOC are trans people themselves, whether professional trans people, whether stakeholders, and we will have that open time to get the views of people, the kind of the general view from people who will be able, anyone will be able to just give feedback into that. We're also working with international organizations from all over the world. We just send them the statements to get feedback from those statements as well. So we try to get as much kind of feedback from everyone around the world as it is. Again, I think nothing will be perfect, and to create a guidance that is global and is perfect and is going to work perfectly well in New York compared to a small little city somewhere else, it's not going to be perfect as such, but I will hope that we create in something that is much better than the SOC 7, that it takes into consideration all the issues that they are, and that we have used the best evidence that is out there in the literature, and the best evidence that is there from clinicians. I mean, we have involved as many clinicians and clinical academics who are been working for many years in trans health, and to give feedback and to approve and to develop those statements. And it has been a very laborious kind of job, really. But again, we acknowledge that nothing is going to be perfect, and there will always be controversies, and some people will be happy with it, some people will not be happy with that. I do hope that it will be as good as we can get, and things as they evolve, as more evidence brings, we'll be able to adapt the standards of care according to the new information.
Thank you, Dr. John. We all understand that medical science is a very dynamic science, and this 8th version itself says that there will be 9th and 10th versions also. Thank you very much for joining us.
Okay, I hope it will not take us. Our idea will be that the version will be flexible, and it will be able to adapt as it is. There are guidelines like that. So I don't hope to get a 9th version in a year's time, because it takes a long time for this.
But that is a part of the process. Like iPhone, every year you get something new, right?
Yeah.
I think now we go back to Kurenshia and Dr. Sharma, and I don't find whether Mr. Alok Saxena has joined. So whenever he joins, he will say a few words. So coming back to Shambhavi and Dr. Sharma, please. Thank you very much.
Thank you so much, Dr. Harish, for winding this up. And special thanks to Dr. John. Sir, this was a treat, because we are so eagerly waiting for the standards of care. There are so many questions that we want to ask you. So we are just going to request you to please stay for as long as you can. And I'm going to request the Coherentia team to move on to the next session.
Thank you, sir. Moving forward, we'd now like to invite Dr. Bela Sharma to commence the mental health session of the webinar. Ma'am is one of the directors of ATHI and is the medical director of KHEM, along with being a life member of WPATH. She is currently the additional director, Internal Medicine, Department of Preventative Healthcare, Fortis Memorial Research Institute, Gurugram. We extend a warm welcome to you, ma'am.
Ma'am, if you could please unmute. You're not audible.
Yeah. So thank you so much for those warm words. Children are very perceptive. They pick up each and every nuance, gesture, and they modify themselves accordingly. It is not only the words that we say, it is the words that we don't say. They also matter a lot. So that is why mindfulness while dealing with growing children is so important, because we don't know what is going to affect their mental health at what stage. Following lines that I'm going to speak are actually from the perspective of a person who does not conform. Every time you tell me to smoothen my edges, I diminish a little. I did not know I had rough edges till you showed me. Every time you turn away, not to hear the questions I asked, I diminish a little. I never knew I sought answers till you showed me. Every time you look at me and look away, as if you can't bear to see my pain, I diminish a little. I never knew I hurt till you showed me. Sarcastic remarks, veiled laughter, snide comments, I can take in my stride. What kills me though is when you say, you love me, but your eyes imply different. And I wonder, if you love me, why is it so difficult for you to accept me the way I am? I would like to invite Dr. Kavita with these lines, starting the mental health section. Dr. Kavita, Dr. Kavita is the founder of Children First. She is, as we have already listened to her earlier also, she has written the chapter on mental health in Indian standards of care. I don't have to say any more. Dr. Kavita.
Thank you so much for those really warm words. But I must say I'm not the only one who wrote that chapter. Just to put the credit in the right place, it was a collaborative effort of a lot of people on the team. Thank you for inviting me today. It's one of the topics very close to my heart. And I was told I have about half an hour. I do have a PPT, and mental health overall as a topic for the entire sort of LGBTQIA community, or looking at it, is a very vast topic. So what I have chosen to do today is to refer to the guidelines which are available in the public domain, and look at the mental health segment of those guidelines and pick out a few things from there and explain the structure and framework that we have arrived at. So my understanding of the audience today is that many of you are medical students, aspiring, hopefully, psychiatrists, mental health professionals, gynecologists, pediatricians, and across the gamut of medicine. And some are already practicing clinicians of various specialties. I'm also aware that there are parents, that there are people who identify with the LGBTQI community. So do I. So I'm going to jump in and start sharing my screen, and hope that you're going to be able to see this. Can you? Can everyone see it?
Yes.
Yes, ma'am, we can.
Yes,
Okay.
ma'am. It's
Okay.
perfectly okay.
Okay. Thank you. So I'm just going to try and make sure that there is usually a sign that lets you go to the slideshow.
So that will be at the bottom of the screen.
Yes, usually is. The thing
Yeah,
is, I can't seem to locate it. I'm just going to try. I do this very often, but this seems to be,
yes.
There we are. So just to give context a little bit more than who I am, is that I've been part of a gender clinic in the urban city of Delhi and NCR since 2007. And I think I have evolved a little bit over time as a person due to the rich interface I've had with many, many individuals who have had, at that point of time, it was called gender identity disorder, gender dysphoria, gender incongruence. And I've seen quite a few things evolve from 2006 when we started this clinic to now. So the central premise really today is that gender and or sexual diversity is in itself not a medical disorder or disease. It's the natural order of nature and humankind. If we are saying this is what it is, it's part of natural diversity, then as the central premise, it's not a medical problem in and of itself. It does mean that oftentimes individuals who identify with this community, they may require a lot more of the interface with healthcare, especially mental health care. But the identification as a LGBTQI individual or a transgender individual or an intersex individual is in itself not a medical problem. And this is something which is new knowledge or new acceptance, although this is how it has been. So I think what's truly happening is that there are some universal truths about diversity that over a period of time, we all have layered with other stereotypes and stories. And this is a process of unraveling some of those stories. So the question really in our minds is, are we mostly looking at the impact of the current social structures and the current prevalent discourse on the psyche of a person who discovers that they are an LGBTQI individual? So just like Dr. Bela was talking, there are two parts to it. One is the inner world of the child who is growing up. And the other is what they see as a reflection from the outside. And the stories that we tell our children become the truth about who they are in their inner world. So then, what is this problem that we're truly talking about? If this is who we are we looking at the tree? Are we looking at the reflection and calling it the tree? Do we have to look at the entire picture? Do we have to look at the child and their inner world and as they grow up to be an adult? Or do we also need to look at when they interface with the outer world, with the social structures, with the family, with the adults around them? What they get back as a reflection is what completes the picture. So one of the things that I often tell myself when somebody presents to me at the clinic is, am I looking beyond the surface? Am I looking at what is underneath the surface as well? What has this child or this young adult received from the people outside? What are the stories that developed that are not part of their inner world, but are layered and reflections of what they received? And if that is so, then what should we do? What are these guidelines about then? Because then what are we trying to find a solution towards? What do we wish to manage? If we are saying it's not what's happening inside the individual is not a medical problem. So then what are we trying to find a solution towards? What do we wish to manage? And the other question is then who needs to manage? Who needs to make the change? Who needs to be accountable for making that change? And I think that brings us to the central framework of the guideline, which is the attempt to say that the problem we are talking about is social. It's equally about the reflection as about the child, young adult, or adult. And if we are able to acknowledge that, if we are able to understand that for the truth that it is, that's when we have to start deciding what to do. So this guideline emphasizes that purely biomedical treatment aimed at the individual is not a complete solution. You cannot lay the accountability of getting, seeking, and accepting help only on the individual. So then who? The solutions that need to be created within the social structures, the structures that do the reflection, that create the stories for our children as they grow up, for each one of us as we grow up. You know, it's very simple. I usually on a daily basis don't look at my resume, so to speak. But when I come to a forum like this, and when Dr. Bela read out, or somebody reads out who I am, it adds to my identity in some way. It makes me feel a little bit more myself. And that's the power of hearing your story through the eyes of another. That's the power of the social structure that I'm interfacing with. And if that is the power, then that's where the solution needs to happen. So the solutions also need to be created within the social structures, by the social structures, for the social structures, and for the individual and their family. So to have a complete holistic solution, this is how the guideline looks at what needs to be done. The second thing that we really wanted is, and I was so glad to hear Dr. John say that they're writing a guideline as associate, which is participative, which has the option of flexibility within the guideline, so that we don't have to keep saying what we said 2 years ago does not apply today. We are already accepting that this is going to be dynamic. It needs to be participative. It can never be perfect. So as a participative guideline, the guidelines emphasize that the role, that changes in social discourse have to play. What is being said about a transgender individual, the transgender community, their health, their care, all of this comprises part of the healthcare. And it also goes on to talk a little bit about what part each social structure can actually aspire to do. And it fosters the belief that each individual in society is responsible for and has the ability to help in creating a safe and affirmative space for an LGBTQIA individual. What does that mean? I think this is the largest premise of the guideline of mental health in the ISOC. If we are saying, and this is often something I hear from, let's say, a medical student or somebody who has just entered the field of medicine, that, I'm an ordinary doctor. You are talking about something which is such a specialized subject, Dr. Kavita. How can I do anything? I don't think I can contribute. There's so many experts who are much better at me, or must be much better at me than me at doing this. But this guideline wants to say that each one of us has the power and has to take responsibility, because we have the ability to matter and to help in creating a safe and affirmative space, not just for the LGBTQIA individuals, which is what the purpose of this guideline is, but for each and every community that has been either marginalized or has been made invisible due to some story or the other about them. And I think that's the spirit of this guideline that I hope is going to get conveyed when you read it. So we've divided the guideline into 3 sections, actually 2 big sections and then subsets. And this first section is about the context, defining the problem, understanding a little bit about how a child in India grows up in the context of their gender and sexuality, how oftentimes a lot of our identity is owned by the people around us when we grow up. The family, the extended family, the teachers, the neighborhood even. The dukandar who's at the end of the gully also knows you because you are so-and-so's son or daughter, or so-and-so's something. Our identities are so intermixed, are so co-owned by our social structures. So many people will know about you as part of that family, that when we want to talk about gender identity or sexual orientation, now imagine what all in this web of interfaces is getting affected. And that's the part that the guideline seeks to try and explain in the beginning, because unless we have an understanding of where this is arising, how this is happening, the solutions or the possible solutions that somebody who's a bystander or somebody who's watching or witnessing, the solutions are not visible till we are able to know how we have participated in propagating some of these social stories. So what the section 1 does is it is purely about not the individual who identifies as LGBTQIA. It is purely about everyone who forms the social structure around them. So what it aims to do is to include the possible role of anyone who's a member of this society, or else who's part of a social structure or the leader of an organization. So it could be anyone. It could be an employer. You could be someone who wishes to do something and is an ally. You could be a sibling. You could be a family member. You could be a teacher in a school, any of those. So the participative bit becomes part of the guideline itself. So many people used to ask me, so when I work with people who are not conforming or are exploring, many times the parents or a friend nowadays or somebody they know will accompany them and say, you know what, doc, what do you think I can do? What do you think I ought to do? And I thought these are such prevalent questions. Why not make a framework where some of these could be answered and owned? So each of these sections attempts to outline and therefore empower the social structure or individual within them by providing specific ways, some suggestions to help support and nurture the diversity. In this case, someone identifying as LGBTQIA. So for example, one of the sections goes like this: I am a system. So I am a social structure. So if I am a school or a college, a higher educational institution, or what can I do as an organization? And there are a set of suggestions. For example, on your form during admission, is there any provision for boys versus girls versus gender non-conforming to make them feel welcome? Or, for example, many of our schools, especially in urban areas, have labels. This is a boys' school. This is a girls' school. Just that, saying there is a space or a school for boys, there is a space or a school for girls. How do you think a gender non-conforming child as they grow up are actually feeling about their belonging in a social structure that does not account for their lived experience? And this may sound small, but it is these levels of microaggressions, these levels of neglect, these small stories that are so intricate and deeply embedded in our social structures that we don't even realize that we are actually ensuring that there is a group of people, a group of children growing up who are actually not feeling like they have a place that they belong. Similarly, for an employer or an organization, a family member, an ally, a mental health service. So why I've put the healthcare provider in a different color is because this particular section does not deal with the healthcare provider. There are many other sections of the guidelines that actually pick up specific healthcare systems and talk about that. This section then goes on to talk about the mental health. If a mental health service wishes to be proactive in actually providing gender affirmative care, then what is it that a mental health service could do? While we were writing these, we also realized that many people who approach us are actually individuals, may or may not necessarily have leading roles within any of these systems and feel quite disempowered, although they wish to do something, they don't know what to do as an individual. So the other section that we made was, I'm an individual. So I'm a family member or a caregiver, what can I do? I'm an employer, what can I do? I'm a teacher, I'm a mental health professional, etc., etc. So the guidelines then go forward in under each of these sections. And we've tried to be fairly comprehensive in each of these sections, provide a dimension or a comprehensive sort of care and suggestions, so that if someone has decided, I'm a teacher, I just want to go to that part of the guideline and have a look at what I can do for the mental health, then they have enough over there and they know which sections to go to, and it makes the guideline not cumbersome to read as a full document, which is again something that we often realize that as soon as you see the comprehensive nature of a document, which is a guideline, it needs to be quite big, it becomes daunting to read for a layperson. So the section 2 then is far more specific about mental health care. And I think the part that I wish to emphasize, but I think in the previous several seminars, this has been pretty beautifully outlined, is that this is about care, not cure. And I think that's the central tenet, but also acknowledging that in the mental health care segment, it is usually both the individual and the family that are usually in need of care. And the reason for that often is, and this is anecdotal, not based on research, but the reason for that often in India is what I spoke about before, that our identities as a family, as progeny of a family, or as the father of someone are so enmeshed that whether it is our surname, whether it is the aspirations of what my child wishes to be, or the dreams of a child, sometimes the enmeshment is huge. Sometimes the legacy of a parent has to be, in a sense, carried on by the boy in the family. And what if the boy is going to turn out to be a girl? And legally, there are so many different gendered layers in our social structures that oftentimes it is not about the individual and their choice. It also becomes about the social relevance and the social implication of their making an individual choice. And I think that's where the family goes through enough turmoil of their own. And therefore, that's something that we felt needed to be highlighted in the Indian context. Then comes the question of why mental health professional, really? So historically, of course, because it was classified as a disorder, because it was part of the mental health difficulty disorder, that's why mental health professionals got involved. And of course, there is a larger likelihood of mental health difficulties because of the theories are that it is also because of the continuous adversity that young people will face that could be responsible for this. But I don't know yet about actual research that determines this, but observations are that this is what it is. The other part historically is that still in many cities and across our country, there is the persistence of an evaluative lens. Why people come to a psychiatrist or a mental health professional, or why the family gets the child or young adult. And this is not usually prompted by the adult. So adults come for themselves in a different way. But when I work with the 18 and minus year age group, a lot of them are brought. They're not coming on their own. And this is because of the persistence of the evaluative lens. So while the medical community and the world is moving towards understanding that gender diversity is actually a natural diversity, it is not a disorder, the social narrative has not moved at the same pace. And this is known across every change, every big change or transition, is that the social narrative will have its own pace. And due to that, oftentimes, someone is brought to the clinic to evaluate. My child is saying this, my teenager is saying this. Do you think they're okay in their mind? Do you think they have a mental disorder that is making them say this? Can you actually create a difference? Can you tell them not to think like this? So this persists as of now, and that is why we felt that instead of just aspirational, we do need to put this, because you have to be objective about something by still talking about the subjectivity that persists. And I do get, I would say 50 to 60% of my coming in clients that I see are children or young adults brought in by the parents for an evaluative lens. So just say, do you think there are medications that will sort of help this child? And that's where the journey is starting. And that's where often the first interface of the mental health professional is. The reason I'm talking about this is then a mental health professional is also someone who has a great opportunity. Because if the family is coming to me, one of the ways I can do it is, okay, I evaluated, no psychotic disorder, no comorbid mental health condition, and tell them, oh, okay, this is gender, nothing to be done, no psychiatric issue, please go back. This is how your child will remain, or this is how you're this thing. But am I sitting at a place where right now I have an opportunity? Can I be instrumental and facilitate the journey of this family and this young individual through the set of circumstances that they will eventually need to go through? So aspirationally, the position and the location of a mental health professional in India right now is full of opportunity. And I think that's what I want each one of the healthcare providers or the potential healthcare providers and the young students to actually look at. Any interface with someone from the LGBTQIA community, especially the T community, is full of opportunity if you know what to do. So the section 2 of the guidelines where we talk about mental health care, I'm going to carry on and talk a little bit about the 3 other sort of parts that we've outlined in the guideline. One is anybody who is saying that they would, actually, let me correct that, anybody who's working in the mental health field as a mental health professional, either as a psychologist or as a psychiatrist, and in many, many cases as a healthcare provider with a different setting. So a gynecologist, for example, or a pediatrician, for example, or an endocrinologist, for example, they will have an interface some point of time or the other. So one of the things we need to educate ourselves as the medical community is the common patterns that are seen in this population specific to mental health. Because this may not be picked up by everyone, because this may not be revealed to everyone. But having a lens that looks out, so there's a famous saying that says the mind manages to see what it is open to, not what the eyes are seeing. So if you're looking for something, you will probably be more likely to find it. So what are the common patterns? We'll talk a little bit about them. I'm not talking about all of them, but I'm going to pick up a couple of them and talk about them a little bit. And let me come back to the slide after that. So what are some of the common patterns? One of the commonest patterns is adversity and its effect on mental health of any individual. And I think the last 18 to 20 months have taught us a lot. Here we were, the entire world, the most resilient of us, in chronic adversity of some sort or the other, going through a set of adverse circumstances, and the world is talking about a mental health pandemic. What do you think is happening? Do you think the genes have changed? As we say, it's genetic. Do you think the people have become weaker, which is one of the myths of anybody who develops a mental health issue or a mental illness? Why do you think the mental health pandemic is occurring? The common sense answer to that is, look at the amount of adversity and the prolonged nature of it and the prolonged nature of uncertainty. I'm asking you to take a step back and think about a child or a person who's non-conforming. They've had a lifetime of this adversity, of uncertainty, whom to say what to, how much to reveal, how much not to, in which state to say it. Am I right in this? Can I do this? Or should I stay inside? So the lockdown is metaphorical. The lockdown for a child who is not able to come out with their authentic lived expression is metaphorical and is experienced in much the same way that the entire community has been experiencing the lockdown. Now think about, will the mental health difficulties have a higher prevalence or not? And that, I think, is something that each mental health professional, each healthcare provider needs to be aware of, that there is the likelihood that there has been a micro level of aggression, some little bullying, some little neglect, some sarcasm, some diminishing, as Dr. Bela said. It's such a beautiful poem. Some diminishing that has not even been acknowledged. And the next time the child will avoid that. So avoidance of something and decreasing the possibility of living in that social structure is also adversity. It's the silent, hidden adversity that we often overlook, but that's adversity. And if we as healthcare providers are able to look out for that, I think a lot of preventive work can be done immediately by each and every healthcare provider. The safety established by someone being seen. I am seen for who I am. And the mirror that Swati will talk about later says that in entirety. These are the patterns that we all need to be aware of. This is far more likely if someone is approaching you as a non-conforming individual. The other thing that I have picked out to talk about today in the common patterns is that oftentimes I find a sense of sympathy, a sense of compassion, that all responses to this adversity will be traumatic. But may I tell you, my experience has been so different. My experience has been that trauma and resilience coexist and balance in such a beautiful way that I can tell you, in my experience, by just being witness to the stories of some of the individuals who have traversed this path, whether they have transitioned or not, but who have just traversed this path, the amount of resilience and the degree of courage that they have shown has been an inspiration to me. I look forward to just meeting them because I know I will learn something and that I will feel good about the power of what a human being can achieve. So please do not forget that it's not going to be only the trauma-informed lens that you would want to look at someone. Please look at their strengths. Please look at what they are coming to a healthcare provider and revealing that identity is an act of courage in our society. And if we are able to acknowledge and receive it for what it is, I think that framework can in itself achieve a lot. Some other common patterns, these are things that you will find written down in most books, in the WPATH standards of care, that when there is transition happening, then transition related care in itself may be a huge amount of stress inducing. Managing of expectations is very important. There are changes occurring when hormonal therapy is going on, which can have related mental health difficulties, but they are in phases, and the mental health professional needs to be aware of them and support through that. And then gender affirming surgery, it's important to remember that this is sometimes not available everywhere. And also very important to remember, not all trans people want it. And that is not something that is a choice of the healthcare provider, that has to be a choice of the individual. And of course, the other bit is the comorbidities of other mental health problems due to adversity, but also due to the fact that they are human beings, and there is a certain amount of prevalence of mental health difficulties and disorders within all humankind. So depression, mood, anxiety disorders, the likelihood is 2 to 3 times higher. Looking out for it, treating it as separate from the condition is very, very important. The other section, so I'm going back to this slide where we said that one section was about the common patterns and being aware of them. The other is about the comorbidities of mental health, the prevalence and management. But the third thing, which is again somewhat different in this guideline, is that the psychosocial and biomedical care practices specific to the individual and family. What does that mean? That basically means that what we've tried to do is who's accountable. We are saying that there are certain ingredients that have led this community and these individuals to be where they are. And let's try and identify at least some of these potential ingredients and determinants and call them out for what they are. They are the determinants of the mental health of this population. So what are those determinants? Some of them through research, through anecdotal evidence, through clinical practice, they have been put down. So for example, one of the determinants which is identified is the lack of present and normative role models. What does that mean? That a child growing up, there's hardly any stories, there are hardly any popular media stories or role models with non-conforming individuals, which are celebratory, which are not just, which are heroes, or the fact that the concept of it is a natural diversity, it's unavailable to most children. Therefore, the risk of children growing up understanding this as a diversity is highly unlikely. So if I know only of a binary sort of gender concept, then how will I even learn that there is a possibility that my inner lived experience may be authentic, and therefore I can speak about it. So if you look at the moon in the reflection and you tell the child that's the actual moon inside the river, and you never show them the moon, it'll take a long time for them to find out whether this is the moon or that is the moon, because you're defining the stories that you're making for the children. So when children do not see, so when children are curious and start looking for, okay, this is how I feel. Is there anyone else who feels like this? Is there any story? Is there a Bhim or a Cinderella or whatever who felt like this? Where are the role models? So what are the possible solutions? And I'm leaving it up to the audience, although the guidelines do suggest a few. Putting in stories, social media. I think Swati is doing, and UNAIDS is doing such a great job in starting off with that. I'd like to talk about one other psychosocial determinant, which is the inequality. Yeah. So there's a much higher risk, and this is across the world. This is not just in India. This has been established across the world, that gender non-conforming individuals are at a much higher risk of experiencing poor health outcomes overall, and a restricted access to healthcare. Now, this could be due to many factors. Some of the ones that are determined by research are, this could be due to an increased risk for isolation, discrimination, both inside as well as outside the healthcare setting. So what are the possible solutions for this? I think one of the solutions is what Curentia is doing with ATI and with the with LHMC. One of the solutions is to increase awareness, is to make the medical curriculum sensitized. All kinds of healthcare providers and healthcare professionals need to be sensitized to this. So the guidelines talk a little bit about this. Coming to the specific mental health care, which is towards, I'm going to take only a few minutes to do this, is the reason I've put this in two different sort of colors is, one is the traditional role that I still find many of my, many of the books that we read still talk about. So if we are not up to, reading the standards of care or the more recent advances, then many of the textbooks still talk about mental health care lens as an evaluative lens. So this is happening across our country. Children are being brought to mental health care professionals for evaluation. So, and I believe that it is going to continue to happen for a while. It's up to us, and it's our responsibility whether we want to take that stance to turn it into affirmative care or not. And I think part of this initiative is to encourage that stance and not keep it evaluative. And of course, one of the major things is intervention and management of coexisting mental health conditions, but also I've put a question mark here. If the mental health professional or the healthcare provider, and I'm talking to all the young doctors here, if you believe that you are the first healthcare provider, and I do this often as an experiment for myself, that I am the first interface with healthcare that this child or this family has come to. I know it's not true very often. They would have gone to their pediatrician, they would have gone wherever. But if I say, if I'm the first one who has heard that this is happening, can I be the single point of contact for an interprofessional interface? What does that mean? Care for a trans individual is always going to be multidisciplinary, interprofessional. They will need different healthcare providers and systems to come together. And as healthcare professionals, I think we all know, it's a secret we don't talk about, how difficult it is to talk to each other and arrive at consensus across different disciplines, across different hierarchies, across different agendas. And if we find it difficult, I often wonder what an individual finds it. So can we say that we will take some part of the responsibility of adopting a central point for interprofessional interface for this trans individual by writing letters, and there's so many different ways. And this is aspirational. the part which is in white, this is aspirational. Then we look at systemic care. Can we start looking with a lens of looking at the family, looking at, does this child or young adult have an ecosystem that they can speak in? Do they have allies? Do they even know that there are other young people who exist who feel this way? Can they find a sense of belonging somewhere? Can we look at it systemically? Can I speak to school? Can I write a letter to the employer, to the organization? And over and above all of this, can I be an advocate? And I think this is a hard part, because oftentimes we're sitting from within our clinics, within our OPDs, and advocacy is not seen necessarily as the doctor's prerogative. So I would urge all the young people, and I think Curentia and the team Curentia is already doing it. So I have high hopes that the generation that is coming will probably encompass this entire slide far better than we have been able to do. So what is the hope with these guidelines and with the mental health care system? And I'm submitting this hope to all of us today, the hope with which this is written. I think the hope really is that we are able to not deny the historical. You know, if we deny the history of what we have said in the past to the LGBTQIA community, if we do not take accountability of what history has done, then we are denying something. We are denying a sense of fairness. So are we able to own up and able to view the historical and the present together as we move into the future? And make it more participative. Make sure that we are listening, but also moving together as we go into the future. And the other hope is that we reorganize the framework of care to include both the actual and the research determinants and the changes required in them. Not just the individual, not just the family. The determinants that are decided by the structures, by the stories, by the daily practices of our systems, which we have created and we need to own up to. And to provide safe and empowering solutions to all concerned systems and individuals so that nobody is able to say, I don't know what to do. They have at least 5 possible solutions and they can come up with 5 more. It is a participative guideline. Please write back saying, I can do this, that, and the other as well, which is beautiful. So the ally part has been written by an ally. The family part, where what should the family do, has been written by someone who came out to the family and then has written this and said, this is what I would have liked my family to do. And I would like other parents to do. So those are the things that we really hope that these guidelines will foster, and accountability, not in the individual. And this is the one thing that I find so difficult and sad sometimes, that the entire accountability of healthcare and care lies either on the individual and adult, or sometimes, if their family is supportive, then on the family. None of the social systems own up to the determinants that are propagated by us as social systems. So I hope that by reading or looking at the framework of the guidelines, we are able to foster some accountability in social systems about themselves as the determinants, and increase the understanding of their own impact, not just in creating these determinants, but also now in trying to undo some or provide care and to make this participative. That's really all from my side, and I'm happy to take questions. But let's get together and let's give wings to all. Thank you. I'm going to stop sharing.
That was simply phenomenal, Dr. Kavita. And, you put things so beautifully and so simple to understand, that we need to view human beings. And that probably puts an end to all questions that anybody would have. Because if that is what we are going to do, then that is exactly what we should be doing. I'm going to allow a few questions here, and I want the students to ask. Because if you are not going to take away these gems from this masterclass that has happened, then you're losing something. So please ask.
Thank you for all the lovely comments. Very, very warm and heartwarming. But I would also welcome questions. And it would be nice if somebody could put the link to the guidelines in the chat so that if anybody wishes to access them, and they have access to the PDF version, which is in the public domain as well. I think Dr. Bela had made a comment, maybe just to me, about the Indian cultural diversity and our, folklore. Where, why don't you talk about it a little bit? I know about Shikandi, and I often quote some of the other.
Yes, actually, diversity was celebrated in Indian culture. And as far back as probably in what we say now, Indus Valley or Sindhu Ghati ki Sabhyata, there were evidences that people lived as probably transgender human beings, or even as gender diverse people. And there was, and if we look at the old like temples and old buildings, yes, it was very well acceptable and it was very well celebrated. In fact, if we go to old Egyptian civilizations, there also the so-called eunuchs were considered to be very brave, and they were considered to be the confidantes of both the kings and the queens and the rest of their entourage. It's only when the Britishers came to India, they probably did not understand how sexuality worked. And for them, it was only like so male or female, and anything in between or away from them is a crime. So that is how homosexuality was labeled as a crime, and that is how the transgender persons, which were actually considered to be respected members of the society. They were cultural members of the society, and they were like moved away from the society and moved to ghettos. So we somehow need to start going back to our history and our culture, and we need to read about them and we need to know about them. That how did we start imbibing something which was not natural to us? And being diverse is actually I think more natural.
Absolutely. Absolutely.
Nothing in nature is identical.
Absolutely. And there are theories that we know about why biodiversity and diversity is essential, how it helps us.
Absolutely.
In each of our species. So, and I think there are so many different layers and dimensions to the diversity that human beings have.
So like even in Ramayana, there's a story like when Bhagwan Ram, he went on Vanvas. So he said people came to bid him farewell. And when he came back after 14 years, he saw there were some people sitting on the banks. So he asked them, what are you doing here? He said, you said all ladies and gentlemen, please go back to your homes. We are neither women nor men. You did not address us. So we did not go. So he actually apologized and he took them with him, and they were again respected and they were honored.
Beautiful.
So that is what our culture was, and we need to reclaim that.
Absolutely. So I do have one question that has come directly as a direct message from Soumya from within the audience. Is it okay if I read it out and attempt to answer it? Or do we have, we don't have time?
Please go ahead, and then we'll move on to the next.
Yeah. So it says, could you please explain what you meant by mental health care shouldn't just be evaluative? I didn't quite get that. Thank you. So Soumya and others, so usually historically, the reason why a child, young adult or an adult comes to a mental health care provider who is gender non-conforming was because they initially got to know about the gender affirming surgery and went to the surgeon. And the surgeon said that until you actually get a letter from a mental health practitioner saying that this surgery is required and beneficial, I will not be able to operate, because this is part of what the WPATH guidelines was. And what Dr. John Arcelis is saying, that maybe there will be a difference in the SOC 8. So basically what started off historically was that surgeons say that because, so they do not need a mental health practitioner's note to do surgery in any other case, because they know what the problem is the organ diseased, is there a problem or a disease inside, and we have to excise it. So you don't need anybody else saying that. But in cases of gender affirming surgery, or at that point of time, it was sexual reconstructive surgery or SRS, what you need to do is take out sometimes perfectly healthy organs from an individual, which is irreversible. So to make sure that there was a gatekeeping, that surgeons did not end up doing this to someone, for example, who was not of sound mind in terms of having a delusional disorder or psychosis or schizophrenia, the rule became that the mental health practitioner was going to be a gatekeeper. So surgeons and endocrinologists, before starting any irreversible treatment, would send to a mental health practitioner. Now it started developing, and this I'm talking about a decade ago, but it persists till now. What started developing is a set of young people who would arrive at our clinic saying, I basically want the surgery, so you give me a letter. So whatever your criteria of evaluation, you give me a letter. So this is a very pressurized place to be in for the young person, because they're trying to prove to the mental health practitioner that A, I am of sound mind, and B, this is going to be beneficial for me. And the onus of it is not even, and because they're speaking for themselves, evaluation or a neutral evaluation is going to become very difficult. But this was the role that was accorded to a mental health practitioner. And in many cases, this still happens. However, over a period of time, the actual role of a mental health practitioner has evolved. And that depends on us. That depends on the mental health care provider about what our approach is going to be. So oftentimes we are still asked to gatekeep, and people will come and say, I don't want therapy. I don't want anything. Doc, just write down that I'm okay to go for surgery. Just give me the letter. That's all I need from you. So I can tell you all the symptoms, and they will read up all the symptoms. They'll read the symptoms and they'll talk about it, because that's what we've constructed as the story. So that's what I meant by the evaluative role. I can give you many anecdotes of the kind of evaluations that also we have done, but I do think that mental health practitioners have to get away from the gatekeeping model and the evaluative role. I hope that answers your question.
Thank you so much, Dr. Kavita. That was really a phenomenal session. And we have a very interesting session right after this. So I'm going to ask Aprajita to take over.
Hello everyone, I am Aprajita Kale, a member of Team Querentia, and now we will be presenting a small role play that we have come up with, and it's titled Log Kya Kahenge. It comments on how society responds to all the issues that we are centered on today, and how we end up focusing more on what people will say rather than ensuring our own happiness and that of those who are around us. We hope you enjoyed the role play.
Good morning. Today we bring to you a question. एक प्रश्न जो आप सबके दिमाग में कभी ना कभी आया ही होगा. हमारे ड्रीम्स, एस्पिरेशंस, डिजायर्स और लोग क्या कहेंगे, इसमें से जीत किसकी होती है? ऑफ कोर्स मत मानो, मनाते रहो खुद को ये कह के कि भाड़ में जाए दुनिया, who cares? सब अपनी कहेंगे, मैं अपनी सुनूं. लेकिन जब ये 3 मैजिकल वर्ड्स लोग क्या कहेंगे लाइफ में आते हैं ना, तब पता चलता है. सो अगेन द क्वेश्चन इज, किसे खुश करना ज्यादा आसान है, सबको या सिर्फ खुद को? आइए देखते हैं.
फुटबॉल खेलेंगे वो तो हमने सारी लड़कों की टीम को देखी. मैम क्यों हम लोग के खेलेगा? लड़कियों की टीम तो फुटबॉल खेल के कहाँ जाओगे? मैम क्या बोल रहे हो, 21st सेंचुरी चल रहा है, हम लोग भी फुटबॉल खेल सकते हैं. खेलते हैं हम. तुम कहाँ जाओगे फुटबॉल खेल के? तुम तो लड़कियों की टीम हो, तुम जाके खो खो खेलो अपना. लोग क्या कहेंगे?
So where do you see yourself in 5 years? In 5 years, I see myself working for this amazing company as an invaluable asset to anything that you give me, and I just feel that I would work very, very hard.
Amazing.
Yes.
Well, I guess that's about it. Thank you. That was an amazing interview.
Thank you so much. I mean,
ये क्या था? She didn't even look at me. फाइल तो खोल के भी नहीं देखी.
See, I'm sure they would consider your application too.
खोल के तो देख लो कि मेरे को भी, मैं भी डिजर्विंग हूँ.
Yes, see, I don't mean to be blunt or rude, but you know, there are other career options as well, and as a girl, I think you would excel in something like PR or designing or anything other than coding.
What do you mean as a girl? Coding is my passion. I love coding. मैं कहाँ जाऊँ? लड़की हूँ तो मैं कहीं भी चली जाऊँ. What is this logic?
See, I didn't mean to trigger you by saying that, but when you came into this profession, I think you did realize that there are some limitations to your gender. I'm sorry, there are some limitations to your gender, and तूने कभी सोचा है कि लोग क्या कहेंगे?
ओहो, आजकल बड़ा हंस के फोन देखने लगी हो तुम. मुझे भी बताओ ये क्या जोक्स है?
अरे मम्मी कुछ नहीं, बस पुरानी फोटोज देख के हंस रहे थे.
मैंने तो कभी देखी ही नहीं है वो.
अरे वो लैपटॉप पे अपलोड कर दूंगी ना, खुद से देख लेना.
पता नहीं कब दिखाएगी तू, अभी दिखा.
अच्छा लो.
वाह, इतनी अच्छी लग रही है तुझे ड्रेस में, बड़ी सुंदर है. Our date yesterday was wonderful. Can't wait to see you again. ये क्या टेक्स्ट कर रही है लड़की तुम्हें?
मम्मी वो स्नेहा, actually she's my girlfriend and we've been dating for like 2 months now.
Girlfriend? You are a girl, she is a girl. How can you date each other?
But mummy, I'm gay. That's who I am. It's not an option.
ये क्या बोल रही हो तुम?
माँ,
आजकल की फिल्म देख के तुम्हारा दिमाग खराब हो गया है. अभी इस लड़की को ब्लॉक करो, और कोई जरूरत नहीं है इससे मिलने की. अभी इसको ब्लॉक करो. तुमने कभी सोचा है कि लोग क्या कहेंगे हमारे बारे में?
भैया जी जरा एक डीओ दीजिएगा और एक वैसलीन का लोशन. ये लीजिए वैसे डीओ, और हमारे मेकअप प्रोडक्ट्स के ऊपर नई स्कीम आ रही है, मैडम के लिए उनको बहुत पसंद है. वो ये सब मैं नहीं देखता भैया, वो अपने आप आएंगी ले लेंगी, कल बुला दूँगा. अब भैया वो लिपस्टिक दिखाइए जरा. मुझे भी लिपस्टिक चाहिए, कौन सी नई लड़की है? पापा वो तो मैं अपने लिए देख रहा था. अपने लिए? अब तो मेकअप नहीं लगाएगा? पापा मुझे मेकअप करना पसंद है. आई ऑल्सो थिंक आई एम क्वाइट गुड एट इट एक्चुअली. ये कैसे
a straight man and I love doing makeup. इस इंसान को ये चीज समझ में क्यों नहीं आ रही है? आज के बाद मेरे को कभी भी मेकअप का नाम नहीं सुनना. आज को मेकअप लगाएगा, कल को साड़ी पहन, फिर तो चूड़ियां पहन. आज तूने कभी भी नहीं सोचा लोग क्या करेंगे तेरे बारे में? Hey Kritika, how was your day? तुम ये सब छोड़ो, पहले मुझे ये बताओ कि जॉब पे कब जाओगे? देखो, मैंने सारा काम कर दिया है घर का. मैंने रिया का खाना बना दिया है, तुम्हारे कपड़े धो दिए हैं. And I think we've already had this conversation, so we are not discussing about this anymore. तुमने देखा रिया भी बड़ी हो रही है, कल को उसके दोस्त बड़े होंगे तो क्या कहेंगे कि उसके पापा हाउसवाइफ है? कृतिका, मैंने तुम्हें कई बार बताया है, मुझे ऑफिस से बहुत ज्यादा जिंदा घर पे लगता है. एंड तुम्हें इस चीज से क्या फर्क पड़ता है कि रिया के दोस्त क्या बोलेंगे? वो बच्ची है अभी. द सोसाइटी इज चेंजिंग. अरे दुनिया के बारे में सोचो भाई, लोग क्या कहेंगे? मैं कब तक ये सोचता रहूंगा कि लोग क्या कहेंगे? Have you ever realized कि मैं यहाँ क्या कर रहा हूँ? मुझे खुद समझ नहीं आता कि मैं खुद से लड़ूं या मैं सोसाइटी से लड़ूं या मैं अपने परिवार से लड़ूं. 30 साल से इस आदमी की जिंदगी में I don't know what I'm doing. Who am I? मेरी सेक्सुअलिटी क्या है? मेरी पहचान क्या है? मेरा नाम तक पसंद नहीं है मुझे. I cannot live under the garb of those. लोग क्या कहेंगे? अगर हम ही नहीं रहेंगे तो लोग क्या कहेंगे? लोग क्या कहेंगे?
We hope you enjoyed the role play. Now I'd like to hand it over to Bela ma'am for further proceedings.
विशाल, मेरी that was a very wonderful role play, I must say. You actually got the spirit of what we are trying to say. You guys are really amazing. Very PPT. Now we're just going to talk about gender-friendly healthcare initiative. Yeah, screen share. Screen share. So I'm going to talk about gender-friendly healthcare initiative. Why do we need to talk about gender-friendly healthcare initiative now? Now we all know that human beings are not binary. That is what we've been talking about. And the WHO has already confirmed that gender diversity or gender incongruence is not a mental disorder. It is a normal behavior. So now we have this segment of population where individuals are coming to us. These are not patients. These are individuals. So they require care. They do not require cure. And we as doctors also need to change our narrative. We need to change our attitude, because now we need to treat these individuals not as patients. We need to treat them as human beings and not as disease or bodies to be cured or treated. Now, this is also compounded by the fact that most of them have a very poor health-seeking behavior. Why? Most of it actually, the onus is on us as medical professionals, as doctors, and also on the society in general. Dr. Kavita has actually very beautifully brought out the whole thing. I don't have to actually explain all this, but I will still attempt to do it a little bit. Now, as healthcare professionals, medical studies, medical students, we know our studies are very binary. We were taught about male body, female body, right from the anatomy and physiology and then pathology and medicine and everything. So we tend to not see what we don't know, what we have not been taught. Secondly, right from the childhood, these people, these children, these growing individuals, they are subjected to constant and consistent negative influences from their homes, from their caregivers, from the playground, from the family, from the school, college, university, workplace, wherever you say. So they learn to be invisible. So they would not go to a healthcare place even when they require some kind of healthcare. However, like I say, times they are changing. With social media, with healthcare awareness, now people are becoming aware of their rights. They know what they are feeling is not wrong and they demand care. And that means we as healthcare professionals need to unlearn what we have learned and we need to learn new things. Which means we as physicians need to take lead and we need to start changing. Which means the medical training needs to change, which means teaching needs to change, and of course, the healthcare facilities need to change. Now that we have talked about why, we need to talk about how. Now, as medical students know, we are very fond of lists and classifications, so I'm just going to put it in classes IIPP, Individual Infrastructure Procedures and Policies. What does an individual do? Person of first contact, whether it's a nurse or it's the say inquiry or the billing counter or the front office person, language is how we communicate. And words can hurt or they can heal. Words are very important. So it is important to know the kind of language that one should use. It is important to use the language not only in front of the individual, but also amongst themselves. No nuances, no gestures which would be derogatory in any form. Your language should be respectful all the time. And please do not use any word which you cannot use at home in front of your children or in front of your parents. That has to be the ground rule. Language has to be respectful. Signages in the clinic, in the hospital, have to be gender inclusive, gender friendly. Ambience of the place, again, has to be friendly so that person, when they walk in, should feel welcomed. They should not feel intimidated. They should not feel scared. Then we come to the documentation. Now, documentation, we have all talked about two-step documentation, which means that when a person presents the papers, ideally, we should ask the person to fill in their own papers. And in case they are not able to, we should be able to help them. Or like in one of the role plays that we had done, I think last time we had done, where a person from the Curentia team helps them fill up the forms because they are aware of gender affirmation, sex assigned at birth, and what is the preference of the person. So what we should do is, this is the two-step documentation. We have to ask what is there in the papers and what the person is affirming. Then staff interactions are very important. All the staff needs to be trained, and hospital should make it a point to have gender diverse individuals who can be employed in the hospital in various capacities, because then the interaction between individuals becomes comfortable. The individual who's coming to the hospital also is more at ease. The hospital gives a vibe that, okay, we are all inclusive, there is a visibility, and the person can relate to the other person more easily. So the staff, again, what we say, lead by example. So it is a very good idea everyone to have a badge where they show their name and this is my preferred pronoun, so that whenever an individual approaches them, they can also say, okay, I'm so and so, and I would prefer to be addressed as he, she, they, or whichever way they are comfortable. So this is about the individuals. Now we come to the infrastructure. Sorry, what happened? Now, reception area of any place is very important, because that is in a way the face of that clinic or the hospital. So the reception ideally should have trans colors or trans flag, which again gives a feeling of welcome and comfort to the individual who's walking into that facility. Now, why we are saying this? Because as Dr. Kavita said, this is the person who has been in a mental and physical lockdown since the very childhood. And they have been in a denial. They have spent a lifetime. So entering into a place where they feel, okay, here is a place where I am welcome, where I am understood. The waiting area, again, should not feel clustered, should not feel, it should feel open, and it should feel like, give a happy vibe, so that, closeted feeling should not be there. Then again, utilities and washrooms are at times the most neglected areas of any place. What we feel is that instead of labeling them as as per the gender, we can have separate stalls, and everybody needs privacy, whatever their gender. So persons can use them as per their convenience, instead of labeling them, okay, this is for this one, this is for this one, and putting that small picture over there of a man in trousers or a person in skirts, or just not labeling them at all. So you have these small stalls, and persons can use whichever they feel comfortable with. Then we come to the consultation chamber. Now, consultation chamber, again, of the doctor or the professional person, whether it's a surgeon or a physician or a mental health professional, that should again feel comfortable, so that the individual walking in there does not feel intimidated, does not feel that he is going in the presence of somebody who's going to judge them. If there is time, I would just like to relate a small incident. Do I have time, Sanjay? Yeah, okay. So this is, Sanjay is laughing. Okay, but quickly I'm going to relate this. So this is when we were looking for a surgeon for our child. And we went to this person who was very highly recommended and who we were told has been doing surgeries. And we walked into the clinic with our child, and he looked at us, and then he says, like, frown on his face, why have you come here? I don't see such patients over here, and you have to come to the other clinic for this. And like, we introduced ourselves, we're both doctors, and he was, no, but I don't see such patients here. So anyway, after that also, his like behavior and the words that he used were not very happy. And of course, it undid the work that we had been doing with our child for a very long time, and we never went back to that person again. And the next surgeon that we went to made it a point to not take our child with us first, and first talk to the person, see the chamber, and see the facility and everything. How's the doctor? How's the receptionist? How's everyone? And only when we felt okay, we are comfortable, then we took our daughter. So that is how, because that is how dysphoria works. It is not only the person individual, it's the parents and the family also who start feeling that pinch. Then we come to the examination room and the procedure rooms. So before the examination, we need to have a changing room. And again, the person, the individual probably would need to know what part of the body would need to be examined and would need to wear a robe or a gown accordingly. So then somebody who is aware, somebody who knows, or somebody who's knowledgeable, again, it would be a good idea to a person who has had a lived-in experience to be there, who can explain and who can be patient, and patient not as a patient maris, but patient as having patience, can explain to the individual how things are going to be. It's a good idea to have another person, so-called chaperone, in the room of the individual's choice, so that both the doctor and the individual feel comfortable. For diagnostics, now there's something which we take for granted. You know, when a person comes for, say, an ultrasound or for an X-ray or for a blood test, you say, okay, you sit over here, you lie down like this, you put your hands like this, you know, you touch the screen like this. But herein we are talking to a person who's very, very conscious of their body, who are very conscious of how they look. And they need to be told in a very calm and in a very convenient manner. And probably, again, the person who's giving them instructions need to be very patient with them and need to explain things maybe once or twice. Like I said, if we have somebody who is in lived-in experience, or somebody who knows the history, or somebody who knows how things work. That is why in gender-friendly healthcare facilities, all the diagnostics, it would be better that they are done in the similar area, and the individual does not have to go to the main hospital, or does not have to react to the people where other other patients are also coming, so to say. For those who require inpatient treatment, now wards is something, of course, most of the places now do not have those, you know, female wards or male wards, especially in the corporate hospitals, but government hospitals still have those labels. So when we are putting a person in that ward for inpatient care, the person should have a say in the ward or in the room that they are being moved to. Again, taking care that their privacy, their confidentiality, and their safety is not compromised, because that is of utmost importance, whether undergoing examination, whether in the consultation, whether during the diagnostics. Everyone has to be very, very mindful that their privacy, their confidentiality, and their safety, security is not compromised. Because see, we are dealing with people who have been in a lockdown from a very long time. Now, here is a small suggestion of how the gender healthcare facility should look like. If you look at it, everything is, so to say, in the same block. Now, except for the things that are in purple, so these are the things that probably everybody would not require, all the individuals. They may just require the, only the diagnostics or the consultation, or probably some kind of counseling, or maybe training. So, and plus legal and ethics department. So these are all in one area. It is also a good idea to have some amount of reading material, some documentaries, and some material available in the reception or in the waiting area, so that the individuals who have some questions or who want to know about something, they can read it, they can see the documentary, and they can interact with people who are there. They can even interact with the staff who's there. They can interact with the persons who are there. They can even interact among themselves. You can have some teaching aids for the individuals who are coming into the clinic. So this is a flowchart. Ideally, all this should be in the on the same floor, except for the ward complexes and the OT and the procedure rooms. But rest of it and should not, the individual should not have to move into the hospital, because like I said, they are not patients. They are individuals who require care, and they really don't have to come in contact with so-called patients who have come there for treatment, for want of a better word. Now we come to the legal ethics and redressal. Yeah. Policies and protocols for any organizations are very important. We already have law in place, but what the organization requires is policies in place and protocols. Protocols for every procedure, for every thing that is to be taking place. Now these policies, they have to be documented, they have to be written, and they have to be visible, and they have to be placed everywhere, in the reception area, in the waiting area, in the doctor's chambers, in the diagnostics, and they have to be available so that any individual who wants to know can see them. Similarly, the protocols, whatever the surgical protocols, whatever the diagnostics protocols, whatever is the latest, they have to be there and they have to be available. They should be available on demand if they are not displayed. Protocols, if they need to be changed, they should be changed accordingly. Then next is redressal mechanisms. Again, we are dealing with individuals who probably are more sensitive than a person who comes to the hospital for treatment. So again, who to go to, who to address, the name, phone numbers, who's the first person on contact, who can be there 24/7, who to escalate, what to escalate, all that should be displayed so that anytime we need, the individual can access those people. To have a great organization, we need to have great teams. And what is the basis of great teams? Of course, great. So G goes for gender sensitive. So the individuals who lead these teams need to be gender sensitive, and they need to be trained to be gender sensitive. They need to be the first responders and redressal. They need to have their mechanisms in place. That is why protocols are so important. And these protocols need to be repeated. They need to be practiced regularly. The person needs to educate themselves and others, and they need to know the policy, and they need to be able to execute that policy. And if there are any changes to be made in the policy, they need to be able to make those changes. Then advocacy and administrative action. What Dr. Kavita said, that advocacy, we all talk about it, but we are not ready to advocate. Yes, an organization which is ready to advocate, an organization which is ready to take up anything and everything on behalf of a person who has come to them and who knows that this is what I need, and even when they don't know what they need. So that advocacy and administration action has to be taken by the person from the great team. And what do we need for that? We need training. We need constant training. We need to train ourselves, and then we need to train the trainer, and we need to train others. And that is where the medical colleges, the hospitals, the medical personnel, the staff, the doctors, we need to take the lead, and we need to train the others. Once we have our gender-friendly healthcare facilities, what do we need? We need to have the certification. This certification, like we have NABH or JCI, we have that stamp. Okay, now this hospital, everybody knows, okay, if I go to this hospital, I get standardized care. Similarly, when I have gender-friendly healthcare hospital or organization or clinic, any individual who's coming to that organization would be sure, okay, whatever I'm getting standardized care, I'm getting what is according to the latest protocols, I'm getting what is required. And I would be sure to have a sensitized and a trained team that is going to be dealing with me. Thank you very much. And any questions?
I guess we'll move on because we are the time crunch is there. So we're going to go on forward.
Thank you so much, ma'am. We're now delighted to invite Dr. Harikirtan Raghuram. Dr. Raghuram is a public health researcher and he currently coordinates the TransCare initiative hosted at Sangat. He is a Wellcome Trust Master's Scholar and has completed his MBBS from Christian Medical College, Vellore, and MSc Health and International Development from the London School of Economics. Dr. Raghuram played a key role in making the Tamil Nadu state mental health care policy LGBTQIA+ inclusive during his time working with the National Health Mission in Tamil Nadu. Dr. Raghuram, we are extremely honored to have you here with us today, and we extend a warm welcome.
Thank you so much, Shambhavi, for that warm introduction. Let me share my screen. Thank you so much, Association for Transgender Health in India, Querencia at LHMC, IPAD, the WHO Collaborating Center, and the WPAD Friends for doing this wonderful session. And it's so great to see over 50 participants staying back so late in the night on a Sunday evening. So really good. I share my apologies from Dr. Aksa, I was supposed to speak with her. Dr. Aksa is not well. Therefore, I'll be speaking on behalf of both of us. So thank you so much for this opportunity to speak about trans care. I've been given 10 minutes, so I'll try to finish within that. So the background is that I know that there are a lot of medical students here and recent graduates. So I was a recent graduate myself, and until 3 years back, I was somebody who knew I knew a lot, being a graduate from one of the best colleges in the country. But at NHM Tamil Nadu, when I wanted to look at how to make the mental health policy trans inclusive, it was a steep learning curve, and I had to learn a lot. And I think a lot of young graduates in the country also need that. And it's with that humility that I'd like to speak about this project. So 2020, Dr. Aksa Sheikh herself had COVID-19 and was admitted. And because of her gender identity, had challenges with the diagnosis, with the treatment she received, and despite being a doctor herself. And this is one of the starting points for the work that we're doing in trans care. And Dr. Aksa, Dr. Anant, and Satindra have been working in advocacy in this area for some time. And after that, my time at NHM, when I went to LSE, I learned more about gender, sex, and sexuality. I did my dissertation looking at gender transition process in India. And a lot of people community members shared about how they were having challenges even accessing basic healthcare, general healthcare, primary care, and it was worsened during COVID-19. And then we had a consultation with the trans community in Bhopal, and this led to our first project, the TransCare COVID-19 project, where we're looking at documenting the experience of trans persons accessing and navigating healthcare in India, especially during the COVID-19 pandemic, with a special emphasis on their mental health. However, when we started this work, one of the key learning points and a key vision and value that we had is that this study has to be done in a participatory manner, because this is a study with the transgender community, and it is I think we all know that there are clear power differences between the research community and the healthcare community, which is largely heterosexual. And when we're doing research with a trans community, there is definitely a power difference there. And when the research agenda and the research methodology and the research dissemination is going to be led by people who are largely cis heterosexual, then that is definitely not going to be acceptable. That is definitely going to be real and not going to be in line with the phrase, nothing about us without us. And therefore, in order to make the research participatory, we did several efforts. One is that in the investigative group itself, we had Dr. Aksa Sanjana, who's a transgender person and an activist from Bhopal, was a collaborator. We had arranged a lot of community workshops. A series of workshops started from the time before deciding the research question to data collection, to data analysis, and for data dissemination. Workshops, often in-person, hybrid, virtual. We did training for building capacity within the community, and not just and for researchers themselves, learning from each other, from trans persons who have the lived experience. And this is a series of training. We also work towards building capacity in the community, for example, for basic counseling skills, and also set up a community advisory board. So this was several efforts we did towards making the research participatory in line with the approach that we took, the community-based participatory research approach, CVPR approach. And the study uses qualitative methods. We've completed 22 in-depth interviews, 6 focus group discussions, and we are now in the process of analyzing the data, and hopefully, and by the next 2 months, we'll be coming out with the outputs of this. Meanwhile, as we started this work, we've been thinking about, as a group of people with representation from the trans community, working in partnership with the community, we were thinking of how we can work towards actually creating real change on the ground. And this is where Dr. Satyendra, who's a co-investigator in trans COVID-19, his prior work with the University of Chicago in creating disability competencies in the medical curriculum. We looked at that work and we thought, why not do a similar work to create competencies for trans affirmative healthcare? And that was what led to our second project, TransCare Meded, where we aim to create a set of competencies on trans affirmative healthcare and to highlight best practices globally in shared decision-making when caring for trans and gender non-binary persons. And in this project, we plan to do workshops in 3 sites, Delhi, Bhopal, and Manipal. Manipal, we have a collaborator, Kasturba Medical College, and then create a set of competencies out of that, review those competencies with stakeholders, and then finally end with a national conference. The workshop will be held in these 3 places with 4 groups of stakeholders with whom we'll have consultative stakeholder workshop, trans community members, health professionals who identify as trans or gender non-binary, healthcare professionals who have experience working with trans and gender non-binary persons, and finally medical educators with an aim to explore and understand what are the challenges that trans and gender non-binary persons face, explore the concept of shared decision-making, and to create a set of competencies on trans affirmative healthcare. After developing these competencies, then we want to review these competencies with the participants themselves, with a wider group of stakeholders, and finally end with a national conference where we highlight best practices in shared decision-making, where University of Chicago will be there, build consensus on these competencies and disseminate these competencies. And this would hopefully kickstart efforts towards advocating for inclusion of these competencies in medical, dental, and nursing curricula. And as I said, the workshops, we already conducted our first workshop at the Hamdard Institute of Medical Science and Research in Delhi. And we had workshops with these 4 groups of stakeholders. The 4th group was a virtual workshop with the health professionals who identify as trans and gender non-binary. And then along with the workshops, we also gave them giveaway. For example, one of that was an artwork by Dr. Trinetra, who was a trans person herself, a comic on Dr. Aksa's life. And already some of our friends have put it up as a form of micro-advocacy in their clinics. The next workshop we're planning to have in the Kasturba Medical College, Manipal, and that is scheduled for the November 18th to 19th. Some of our early success in this work in TransCare, we already had a meeting with the National Human Rights Commission during the time we were in Delhi, and we had almost 1.5 hours telling them about our work in TransCare COVID-19 and TransCare Meded, sharing what are the challenges trans persons are facing in accessing healthcare settings. And this has already led to the National Human Rights Commission issuing a notice over welfare of transgender persons in Delhi. Along with this work, we've also been looking at how we felt that one of the limitations of TransCare Meded is that while we are creating these competencies and looking for including them at the national level and at individual medical college. We felt that it is more of a top-down approach, and there needs to be work from below, just like how Kuranshia you were doing in your own college. Yes, and that was where we thought of that. While there are a lot of ambassadors like you working in different colleges, there needs to be a space for creating a network of people like you, MBBS, BDS, nursing students, and early healthcare professionals, where people can learn from each other, work together, get connected with seniors in this area, and create a platform for that. And that's where Transcare Campus Ambassadors work is coming. I'll share a link for this later. And anybody, young graduate students who are interested in learning more about this, please fill in the form. And meanwhile, one of the issues that has come up in our Transcare coordinated work is that a lot of people have shared about how challenges in accessing healthcare is also there in terms of challenges in accessing vaccines. And this has led to our fourth project, which is the Vaccine Equity Project, where we are looking at vaccine access among trans and disability communities, and which is again a qualitative study with a participatory approach funded by the Sabin Vaccine Institute. This is the Transcare team: Dr. Anand, Aksha, Satyendra, Dr. Amir from UCMS, Dr. Keertana from KMC, Deepak, myself, and a lot of people from the Sangat side. We also have community collaborators. This is the team from the Chicago side in the Transcare Meded project. And so in summary, the Transcare initiative brings together academics, researchers, activists, practitioners, and trans community representatives to conduct participatory research, advocacy, and education in the intersection of trans identities, health access, and mental health. And we do this with the following 6 values. One is that we're working towards improving equity in healthcare. And we do this understanding that there is intersectionality in these experiences of marginalization, and therefore it is important to not just look at one specific gender identity alone, but also a host of identities and host of power differences that come in this setting. Third is that we recognize lived experiences expertise. It does not need an MBBS, an MD, a PhD to be an expert in understanding trans issues. Biggest expertise is having that lived experience of being a trans person. And because of that, we work in partnership with the communities in line with the phrase, nothing about us without us. And we work towards high quality ethical academic scholarship, but at the same time, we also work towards creating real change through policy advocacy. So Transcare COVID-19, we started with conducting a qualitative study with an open mind, looking at what are the challenges trans persons are having in healthcare settings, using those findings and other workshops towards finding out how we can make a change, at least in the medical curriculum, in a top-down manner, and in a bottom-up approach is the Transcare Campus Ambassadors program. To end with, I'd like to just reiterate that right now, we are in 2021 October. In 2019, just 2 years back, we had the Transgender Persons Protection Rights Act. And then 6 months down the line, we had the Transgender Persons Protection Rights rules coming in. Recently, we had the Madras High Court statement about queerphobia in medical education. And then again, from the Kerala High Court judgment about queerphobic sections in the MBBS textbook. And now seeing this work that is happening through Querencia with the Indian Standards of Care, the gender-friendly healthcare initiative, I think we are in a great position. This is a great policy window for us to work together to make our country trans-affirmative, to help our transgender colleagues, our transgender friends, to be able to achieve the same healthcare that anybody in India should be able to achieve. Thank you very much.
Thank you, Dr. Harikirtan. That was really powerful. And this is something which all medical students should take this message, they should take home. How to put into practice or how to bring about change. And this is how we do it. So going forward, there is a great crunch for time, but we have a very interesting guest for you. And we have a very interesting movie which says so much. So let's watch that.
फास्ट काटना है उसको, जल्दी जल्दी भाई, जल्दी जीतू।
मुझे थैला छोड़ना। ए राजा, उड़ा क्यों नहीं रहा?
नहीं, थोड़ी देर कर लो। मुझे नहीं खेलना।
So let me invite the person behind this movie. Swati, please come on. Please tell us what all this is about and what you are going to do in the future with this. Over to you. I'm not going to waste time in introductions for you.
No, don't. Because after all the people who came before me, I'm like so humbled to be in the same room, and very generous of all of you to invite me. Now, you know, this is a very simple story. And, but what's nice is when experts in this field look at the same story and find meanings and layers. And I think that is, you know, sometimes for a creative person, a work just gets born and you don't even realize all the things that came together for it to, you know, for it to touch people the way it is doing the world over. And I think, you know, if you, I think that segment of Log Kya Kahenge is so important in this, because without using any words, you know, as a mother, one intuitively knows when one's child is happy, when one child is, you know, in a state of wellness, and also knows when the child is not happy, also knows when there is an inner struggle. It's, you know, and I think if you look at it, the mother walked in, she got that little shock. And she was also aware of the fact that her mother-in-law is there. But when she gives that one look to the mother-in-law, something about that mother-in-law's presence, something about the fact that, you know, and that just, in that split second, she decided to be a part of the child's moment of, you know, fun, enjoyment. And I think, you know, as parents, we think that, you know, everything that is numerical, I feel, how much your child weighs, what are the marks once the child gets, how many friends does he have, कितनी बड़ी birthday party थी, कितने लोग आए थे, all those numbers add up to the, you know, the health of your child. But that's not true, really, you know. And I think, you know, if we give, and that's why people like Kavita are so important in our lives, because if feelings and emotions are given the same darza that you give to numbers, I think the world would be a better place. So when this work came out, and you know, there is a person who is like my mentor. She's a trans woman in Sydney. Her name is T. Uglo. She runs the creative lab for Google. She saw the film and she was interviewed on what she felt. And there's something she said, and I would like to share it with you. She said, you know, when the mother came, my heart stopped. I didn't want to see it. I didn't want to, you know. And then the fact that actually what I was expecting didn't happen, it took me a while to really grasp that. And then we have to, all of us, whether we are from the medical community or from a creative community or just normal human beings, we have to ask ourselves that, why is that violence normal? Why do we think that that is normal? And then question. And then in our capacities of being in a family with nieces, nephews, children, or colleagues, or in a work environment, we have to use that same thing, you know, because as we know, and Kavita would also, you know, it's so much easier to you know, I don't want to use the word fix, but to heal children than to heal broken adults, you know, because what happens is then the anger, the violence, the, you know, that kind of creates other problems for you, other health problems for you, not just, you know, mental health issues, physical health issues, emotional health issues. And I think, you know, what we need to do is just actually just make some way for love. So I know there'll be acts, and then there'll be, you know, books written and manuals, but somewhere in just the capacity of being a human being, how difficult it is to love. And we have to ask ourselves, why is it, you know? So I think that's, you know, what the film did. And I'm just so excited about the fact that all the experts in this field, you know, are kind of helping my baby walk. And I just wanted to say, you know, about 4 years back, I had done a film for Times of India called Shindu Kala. You will find it in YouTube. And that is actually in Bengal. And this is Durga Puja time. We have this incredible piece de resistance called Shindu Kala, the last day, you know, Jab Sindoor and the goddess. And that's a beautiful festival till you sit down and think, oh my God, but this only married women can play. And it is a shubh if a divorcee, if a single woman, if, you know, a trans woman, if a widow plays. And I think, you know, I got a lot of help, and kind of society as Bengali women, they embraced it. And then it wasn't left for a priest to make a statement. And in that, I understood that, you know, if a piece of work can make the viewer the activist, then we don't need, so, you know, we can help ourselves. And that's what I would like. That's my vision for humanity, our ability to help the ones we ourselves love. It's so stupid that you love someone, that's your child, that's your brother, that's your sister, but you have a conditionality that I have a point of view on your vagina, on your penis, on who you love, who you desire, how you feel, what's erotic to you. So, I think that I would like to say, but I have a really good news to give you guys. I mean, I need all 49 of you who are there to pray for me. What we are trying to do is use this film as a part of the curriculum. And we just had a meeting. Sanjay was there. There was also the UNESCO head. There was, the UNICEF head. There was also Dr. Bilali. And we all were saying, how do we take it to the teaching community and to NCRT and sensitize teachers who, because they are between the teaching community and between the family. They are the first responders, and how do we make our first responders really respond with their heart? It's not that, oh, I haven't read the transgender manual, so I don't know how to deal with this 5-year-old. So that's what I want to say. And thank you again.
Thank you, Swati. And I promise you, you have 49 ambassadors.
Yes.
Actually, I'm wrong. You have 800 ambassadors, because that is how far your clip has gone. And I promise you, on behalf of all people who are here, that we are going to make this happen. We need our teachers, people who get associated with growing minds, to be mindful. It is our promise to you for bringing this out so beautifully. And we are going to really push this. We are going to knock the doors of the highest offices and tell them, look, this is how we educate. We don't require textbooks to do that. We require human beings to allow other human beings to be together. And if we as human beings are really social animals, then can we not be human and give space to each and every human form that is there? I was so thrilled to see this movie, and I know I speak for each young person who has seen this. And you took me back to when I was in my 20s and I wanted to change the world. I still do think I'm stuck in that space, and we will do it. We will do it. Thank you so much. There is one last thing that I need to address, and this is the end of the course that we have put together, this course on transgender health. And we have been at it for the past 4 months. We have covered it in 4 webinars that we did. And today, when we finish off with the most important aspect of the mental health, the most important aspect of the human part of it, we do want to know that what can you do? What can I do? Well, we as responsible human beings, we as the people who will decide what the society is going to be, can work for gender-friendly healthcare facilities. We can ensure that we have gender-friendly educational institutes. We can ensure that whatever the laws or the acts that have been put together by the government, by the bureaucrats who have taken so much of consensus to write, that we ensure that they are translated into action. This is what we need to do. We need to call out to the other person that he needs to be mindful. This is what we can do. And we, in our own way, can be human we in our own way can be human. Let us be human. Let us be human beings. We are not bodies. We are people who can make a change. Please don't grow old. Make the change. Forever young. Bob Dylan for you. Thank you so much for staying back and remaining with us. We still have 47 people who are here, and we are going to put this. This is already there on YouTube, and it is going to be there for people to watch later. And all I have to say now is good night and thank you for being with us. Thank you so much.
Sir, we'd like everybody to turn on their cameras for a short while so that we can take a quick screenshot.
I guess 10 minutes over time is allowed, no?
Yes. Even by the Swiss.
I think I'm the culprit. You should have told me.
So do we stop smiling or do we carry on?
Just a second, sir. Just taking a few more.
Okay. Take a countdown. 3, 2, 1. Done.
And do we have time for our woohoo?
Sure, sir. Yeah.
So there's always time for that.
There's always time for that.
So we always end on this note, and I would all like you all to say from your heart, woo-hoo.
Yes.
So, woo-hoo.
Woo-hoo.
Woo-hoo. Thank you so much.